So good afternoon, everyone. You can hear me?
Yeah, we can hear you. Hello, Sam.
Yes, assalamu alaikum.
Yeah, we can hear you.
أهلا Dr. Walid. So, Dr. Abdullah, you are ready?
Yes, I'm ready.
Yes. So good afternoon, everyone. This is Noor Lami, cardiac surgery resident from Medina Cardiac Center. Me and my colleague, Dr. Muhammad Al-Aboud, will be moderating this session in the lab. So we will have 4 sessions for today. First session is surgical management for mechanical complication post-MI, presented by Dr. Abdullah Al-Ataibi. And followed will be carotid disease combined with coronary disease, STITCH trial, and freedom trial with Dr. Mariam Al-Umair at the end, inshallah. So we'll wait for the others to join, and we'll be starting in 1:05. Tamam, Dr. Abdullah?
Okay, sure.
Okay, thank you. Sorry, Dr. Abdullah, you have any supervising consultant with you?
No, unfortunate. I tried, but
Okay, no worries. Okay, Dr. Abdullah, you may start, please.
Assalamu alaikum. Good afternoon, everybody. This is Abdullah Al-Ataibi, R4 cardiac surgery resident at King Fahd Medical City. And today our talk going to be about surgical management of post myocardial infarction complication. So I will talk about pre-war rupture, LV aneurysm, and post-infarction VSD. I will go through each the incidence, pathophysiology, clinical presentation, diagnosis, preoperative care, and operative technique. So as an introduction, while the incidence of mechanical complications after MI is uncommon, these complications account for 15 to 20% of deaths after acute MI. Such complications are less common with improved medical management and catheter-based intervention. So, talk about pre-war rupture. Incidence in left ventricular pre-war rupture is a relatively common finding in autopsy series of patients expiring early after acute MI, occurring in 10 to 30% of such patients. It's more common in elderly patients, female, and in patients suffering their first infarction. The peak incidence occurred at a median of 5 days after infarction. Rupture tends to occur at the junction of viable and non-viable and necrotic myocardium. It's a life-threatening complication that requires early interventions. And those who survive the initial acute 2 weeks phase of ventricular free wall rupture without diagnosis or with the therapy, this entity will ultimately evolve into pseudoaneurysm formation of the left ventricular free wall. These later phase patients have generally undergone some pericardial healing at the site of infarction, and their management more resemble of that of patients with chronic true aneurysm of the left ventricle. But pathophysiology, post-infarction, left ventricular free wall rupture can present in acute, subacute, and chronic phases. Acute rupture generally results in acute pericardial tamponade, followed by shock and electromechanical dissociation and death within few minutes. While subacute may initially involve a smaller ventricular wall tear, which becomes partially sealed by a clot and pericardial adhesions. A chronic rupture, by definition, of left ventricular pseudoaneurysm formation, which results when pericardial adhesions are sufficient to prevent free wall rupture for 2 weeks or more. Chronic left ventricular pseudoaneurysm generally have a narrow neck, contain no myocardial cells in the wall, and have a high propensity to convert to an acute rupture. For diagnosis, when patient status allow for it, echocardiography is usually used for diagnosis. And subacute form of free wall rupture pericardiocentesis can help to temporize the patient hemodynamic status while preparing an operating room. Operative technique, repair usually is performed with the on-pump or can be done off-pump. Successful repair requires the suturing of healthy myocardium, most commonly with the horizontal mattress, buttressed with the pledget. Pericardial or Dacron or Pitif patch can be used as an epicardial repair. The use of intra-aortic balloon pump is commonly necessary for preoperative stabilization and for weaning from bypass. So this diagram shows the operative technique for rupture of the free wall of the left ventricle. As you can see here in image A, left ventricular free wall rupture and limited infarctorectomy, closed usually with horizontal mattress sutures, buttressed with the 2 strips of Teflon felt. Then the whole area is covered with Teflon patch, sutured to a healthy epicardium with a continuous Prolene suture. Alternative technique, the Teflon patch can be glued using biological glue. Coming to left ventricular aneurysm, definition has been strictly defined as a distinct area of abnormal left ventricular diastolic contour with systolic dyskinesia or pericardial.
Can I stop you, Abdullah?
Sure.
So if you just go back into the pseudoaneurysm, it just, as we mentioned last week, it's very important to recognize that you usually first in an acute phase, the patient will die on the moment of the acute or the free wall rupture, so they won't make it. So those patients who usually we see is the subacute and chronic, right? So it's very important, as we mentioned last week, that to recognize the life-threatening condition and its high mortality. And you have to, in terms of operative planning, you have to consider a peripheral cannulation because you're not sure once you open the sternum, if that's a small fibrin clot that's sealing the tamponade, if it's disrupt, the patient may bleed to death. So one of the preparation before you go on bypass, maybe you'd have to open the groin and go on bypass, or at least to be ready to go on bypass peripherally before you open the sternum. So this is a very important for in your life, like if you encounter similar condition. and in preparation for your exam.
Sure. Thank you, Doctor. So for ventricular aneurysm, it has been strictly defined as a distinct area of abnormal left ventricular diastolic contour with systolic dyskinesia or paradoxical bulging. Yet a growing number of authors favor defining left ventricular aneurysm more loosely as any large area of left ventricular akinesia or dyskinesia that reduces the left ventricular ejection fraction. For the incidence of the aneurysm, usually patients suffering from acute MI has varied between 10 to 35%, depending on the definition and the method used. Absolute incidence of left ventricular aneurysm may be declining because of the increased use of lytic therapy and revascularization early after MI. Pathophysiology, development of the true left ventricular aneurysm involved two principal phases. Early expansion and late remodeling phase. For early expansion phase, the early expansion phase begins with the onset of MI, and ventriculography can demonstrate a left ventricular aneurysm formation within 48 hours of infarction in 50% of patients who develop ventricular aneurysm. The remaining patients have evidence of aneurysm formation by 2 weeks after infarction. Factors contributing to the left ventricular aneurysm formation: preserved contractility of surrounding myocardium, presence of transmural infarction, lack of collaterals, and lack of early reperfusion, elevated wall stress, hypertension, and ventricular dilatation and wall thinning. Late remodeling phase. The remodeling phase of ventricular aneurysm formation begins 2 to 4 weeks after the infarction, when highly vascularized granulation tissue appears. This granulation tissue is subsequently replaced by a fibrous tissue 6 to 8 weeks after the infarction. A myocytes are lost. Ventricular wall thickness decreases as the myocardium becomes largely replaced by fibrous tissue. In larger infarcts, the thin scar is often lined with a mural thrombus. For clinical presentation, usually angina is the most frequent symptoms, followed by dyspnea and arrhythmia, either with atrial or ventricular arrhythmia, which may produce palpitation, syncope, or sudden death, and thromboembolic phenomena, rarely, but sometimes may produce symptoms of stroke, MI, or limb ischemia. For diagnosis, ECG frequently demonstrated a Q-wave formation in the anterior lead, along with persistence anterior ST elevation. Chest radiography may show left ventricular enlargement and cardiomegaly, but not usually specific. And left ventriculography is the gold standard for diagnosis. Echo is also sensitive and specific. It can detect mural thrombus and often distinguish false aneurysm from true aneurysm by demonstrating defect in the true ventricular wall. Cardiac MRI is most reliable means of assessing left ventricular volume in the presence of left ventricular thrombus can detect mural thrombus. For radionuclear scanning, reliably detects the left ventricular aneurysm, and it can be helpful early after infarction to differentiate a true aneurysm from hibernating myocardium with reversible dysfunction. For indications, because of relatively good prognosis for asymptomatic left ventricular aneurysm, no indications for repair chronic symptomatic aneurysm are established, but some relative indication for the ventricular aneurysm, including documented expansion, angina, congestive heart failure, arrhythmia, rupture, high risk of rupture, formation of pseudoaneurysm, or embolus event. The STITCH trial has suggested that little benefit is obtained in terms of survival or symptoms in patients whom on average have smaller akinetic aneurysmal segments. For operative technique, we have a linear closure, which usually favoring the anterior aneurysm, plication for small with no thrombus formation, circular patch, mostly favoring for inferior or posterior aneurysm, and endocardial patch. Usually, median sternotomy is approach for each one, and ascending aortic cannulation plus to the right atrium are cannulated. Then the left ventricular vent is placed in the right superior pulmonary vein, pericardial diffusion and divided, then the aneurysm is open. While the aneurysm wall open, thrombus removed without injury to the papillary muscles. Now coming for the linear repair, a fibrous aneurysm excised, leaving around 3 centimeters of rim fibrous aneurysm wall attached to the healthy muscles. Then the aneurysm wall are closed in the vertical line between 2 layers of Teflon felt, 2 layers of zero monofilament interrupted horizontal matrix suture are reinforced with 2 layers of running 2O monofilament sutures. For circular patch repair, same aneurysm wall is incised and inferior aneurysm. Then the aneurysm wall is after excision, leaving 2 centimeter rim of fibrous aneurysm wall attached to the healthy muscles. And then it is closed with Dacron patch using interrupted 2O monofilament horizontal matrix sutured with reinforced platelet. For endocardial patch, without excision of the aneurysm, the ventricular defect is closed with a Teflon felt patch using 3O Prolene suture secured at 3 or 4 points along with the suture line. Additional 3O platelet horizontal matrix may be used to achieve hemostasis. Then the aneurysm wall is closed over the Teflon after resecting the excess aneurysm tissue. A double row running vertical 2O Prolene is used. For in-hospital complication of ventricular aneurysm repair, usually most common complication is low cardiac output, counting around 40%, ventricular arrhythmia around 20%, respiratory phase around 20%, bleeding around 7%, and dialysis dependent renal failure 4%, strokes accounts for around 4%. For the late results in the prospective randomized stitch trial of 1,000 patients with ejection fraction of 35% or less and anatomy amenable to ventricular restoration showed that on average, left ventricular restoration technique did not affect the survival relative to coronary bypass grafting alone. Now for post-infarction PST.
Again, sorry, can I stop you, Abdullah?
Sure.
So for left ventricular aneurysm, most of the advanced cardiac center where they perform this procedure, I'm not sure if you guys have seen it, they do none of the procedure that's mentioned in Lawrence textbook, but the new procedure they usually do, and it showed effective result. It's called the DOR technique. Have you guys heard about this DOR procedure or DOR technique? DOR. If not, I would recommend you. I don't have it here, but I can maybe show it when I present my slide later. It's basically similar to the circular patch. So you make your incision 2 centimeters away from the LAD on the aneurysm. You open it, you resect all the aneurysmal part. And most of the patient who had LV aneurysm, they will have LV dilatation. So they aim, and the DOR procedure is to reduce the LV cavity to an effective left ventricular insystolic volume index 60 ml per meter square. And they showed in the STITCH trial, actually, I'm not sure who's going to present it, but one of the things they looked at it, the mortality related to the LV, ventricular systolic volume index. And if you leave the LV more than 60 ml, there's less survival. However, if you reduce the LV volume to 60 ml per meter square, it ensures better survival for the patient. Okay, so in the door technique, they will decrease the LV volume to 60 by a balloon, specific balloon. They insert it into the LV, they inflate it to 60 ml, and then they do a purse string, like a stitch around the opening. You do like when we do the purse string for the cannulation, they do it around the opening and they tight it down to that volume, and after that they deflate the balloon and they pull it out. Now the center, they don't have that specific balloon, they do it with a glove, like, you know, the hand gloves. They fill it with a fluid, like a saline, 60 ml per meter square according to the patient body surface area, and they put it inside the LV. They do the purse string, and then once they purse string and they tight the purse string, they deflate the balloon, they purse it. So the saline will be inside the ventricle, and then they suck it out and they remove the glove. And then after that, they do either the circular patch or the 2 Teflon strips around it. So it's exactly similar, but the idea is to be more specific into for how much you're gonna reduce the LV volume. And the key is to reduce the LV volume to 60 ml per meter square, LV and systolic volume index. Okay, so I would recommend you guys to search about the door procedure and you will see it. I think, I'm not sure which paper, but they have it also in drawing. So it's very nice. Thank you.
Thank you, Dr. Ahmed. For the BSDs, occurs in 1 to 2% of all acute MI, typically 3 to 5 days after the onset. Rupture of the interventricular septum with the resultant ventricular septal defect can occur as early as hours after the infarction or as late as 2 weeks. This timing correlates well with the maximum tissue necrosis from the acute myocardial infarction with minimal healing having occurred. Patients with post-infarction BSD are most likely to be men because women are less likely to present with transmural infarction. Pathophysiology, post-infarction BSDs generally involve transmural infarction of the interventricular septum with subsequent dissection of the ventricular blood flow into the septum myocardium, resulting in ventricular septal defect. Without surgery, 50% of patients with post-infarction BSD will die within 24 hours and 80% will die within 4 weeks. Approximately 7% of patients live longer than 1 year, and for the locations, 3 locations, apical and anterior, which is the most common, or posterior inferior. Post-infarction BSD results in left to right shunt of a variable magnitude with diversion of blood flow from the systemic to pulmonary circulation and low cardiac output state, ultimately into leading to cardiogenic shock. For the type of rupture, we have simple through and through opening, complex multiple with remote. Heart failure and cardiogenic shock are important prognostic factors. Left to right shunt prognostic factor and correlate with the hemodynamic stability and can affect the cardiac output by increasing the pulmonary vascular resistance, high shunts, increasing in diastolic pressure and low cardiac output, ultimately leading to multi-organ failure. LAD occlusion causing anterior septal MI result in anterior and apical defects. In about 1/3 of patients with rupture occur in the posterior septum after an inferior septal infarction. Those posterior papillary muscle is often involved in posterior inferior septal defects. For clinical presentation, presence of new systolic murmur is noted radiating to the left lower sternal edge and recurrent chest pain may develop, and hemodynamics may deteriorate with the onset of dyspnea, tachycardia, hypotension, and oliguria. For diagnosis, on the right side heart cath, there is a setup in the oxygen saturation between the RA and PA, and currently Doppler echocardiography can most definitively demonstrate the size and location of the VSD. Cardiogenic shock in the setting of post-MI VSD is a surgical emergency. Often the use of balloon pump placement will be required prior to operative intervention. If the patient is already in multi-organ failure and survival from emergent surgery is highly unlikely, a mechanical bridge or catheter closure can salvage the occasional patient for surgery and buy him more time to a stable state in the future. Less than 5% of patients can be totally stable and undergo surgery in semi-elective basis, with the operative mortality in general ranges from 30% to 50%. Mortality after surgical intervention is caused by low cardiac output in half of the time, and recurrent or residual VSD a quarter of the time. While residual defect in unstable patient should be immediately addressed, delayed repair is favored in hemodynamically stable patient with residual VSD. Long-term survival is more commonly quoted between 40 to 60%. For preoperative management, medical management resolve around reduction of the left to right shunt by reducing systemic vascular resistance and the LV pressure. Placement of balloon pump usually helpful. Percutaneous closure rarely works because the adjacent muscle is fragile and the mitral valve and papillary muscle are close in proximity. For operative technique, preoperative coronary imaging does not convey a survival benefit, as revascularization of full thickness infarcted tissue is not helpful. However, some reports show the benefit. When possible, necrotic tissue should be debrided and sutured, placed through non-infarcted tissue to maximize suture line integrity. And the concept of preservation of LV geometry plays a crucial role in the preservation of left ventricular function. Advantages of exclusion technique: there is no resection, no LV depression, maintained ventricular geometry and enhance the LV function, avoid tension on friable muscle to diminish post-operative bleeding. So in general, we have two techniques, infarction exclusion and infarctectomy or excision technique. The key principle in surgical intervention is to minimize tension. Prosthetic material is crucial in achieving this end. Small anterior and apical defects can be closed by suturing the free wall of the RB and the LV with the septum. So principle for infarctectomy repair. Transinfarct approach to the ventricular septal defect through trimming of the left ventricular margins of the infarct back to viable muscle to prevent delayed rupture of the closure, and conservative trimming of the RV muscles as required for complete visualization of the margin of the defect. Inspection of the left ventricular papillary muscles and concomitant replacement of mitral valve only if there is frank papillary muscle rupture. Closure of the septal defect without tension, which is most instances will require the use of prosthetic material, and closure of the infarctectomy without tension with the generous use of prosthetic material as indicated, and epicardial placement of the patch to the free wall to avoid strain on the friable endocardial tissue. But strength of the suture line with the pledget or strepton or Teflon or similar material to prevent sutures from cutting through the friable muscle. While principle for exclusion technique, no infarctectomy unless necrotic muscle along with the ventriculotomy is sloughed during closure. bovine pericardial patch, or either oval or triangular shape, is sutured securely with the continuous proline around the defect to exclude it from the LV cavity. Where necessary, full thickness bites are taken to the epicardial surface and anchored by strips of pericardium or Teflon. An anterior patch is anchored to non-infarcted septum below the defect. Then the non-infarcted endocardium of the anterolateral ventricular wall. If the infarct involves the base of the anterior muscle, full thickness anchored bites are used. A posterior patch is anchored to the mitral annulus non-infarcted septum and through the infarcted posterior wall along with the line corresponding to the medial margin of posterior papillary muscles with a full thickness anchoring. Closure of the infarct rectum using strips of pericardium or Teflon. When possible, the infarcted right ventricular wall is left undisturbed during the closure. So for apical VSD, usually apical amputation where necrotic apical myocardium is resected back to the LV and right ventricle and the septum. The remaining apical defects is then closed using interrupted mattress suture when orthopedic, securing the left and right ventricular wall to the interventricular septum with a strip Teflon outside the left ventricular wall and outside the right ventricular wall on the either side of the interventricular septum. After all sutures have been tied, the closure reinforced with running suture to ensure hemostasis. For the anterior VSD with the infarctotomy technique, the transinfarct left ventricular incision to expose the anterior septal rupture. The incision is made parallel to the LAD through the center of the infarct in the LV wall. Then the repair of the anterior septal rupture by application of the free anterior edge of the septum to the right ventricular wall with the interrupted one orthopedic mattress, suture buttressed with strips or Teflon. Then the ventriculotomy is then closed as a separate suture line, again with interrupted mattress using 1O, buttressed with the felt strips. And the second running suture is used to ensure the secure left ventriculotomy closure. For the large anterior VSD using a Dacron patch, which is swung to the left side of the ventricular septum with interrupted mattress suture, each of which is buttressed with a pledget of Teflon on the right interventricular septum and interiorly in the epicardium surface of the right ventricular wall. All sutures are placed before the patch is inserted. Additional pledgets are placed on the left ventricular slides overlying the patch to cushion each suture as it's tied down to prevent cutting through the friable muscle. For the repair of the anterior post-infarction VSD using the infarct exclusion technique, standard ventriculotomy is made in the infarcted area of the left ventricular free wall. Anterior patch is fashioned to cover the VSD, and the internal patch is secured to normal endocardium with continuous monofilament suture, which may be reinforced with a pledget of mattress sutures. Then the ventriculotomy is, which is outside the pressure zone of the left ventricle, may be repaired with a continuous suture, and the endocardial patch is secured at the 3 levels, above and below the septal rupture and beyond the ventriculotomy. For the posterior VSD using infarctotomy technique, repair of posterior septal rupture when necrosis of substantial portion of posterior septum requires the use of patch, and interrupted mattress using 2O are placed circumferentially around the defect. These sutures are buttressed with the felt pledget on the right ventricular side of the septum and on the epicardial surface of the diaphragmatic right ventricle. All sutures are placed, and then the dacron patches slide into the place of the left ventricular side of the septum. Then the patch are sutured tied down with the additional felt pledget placed on the top of the patch. As each suture is tied, to caution the tie prevent cutting through the friable muscles. The remaining to be repaired is the posterior left ventricular wall defect created by the impactorectomy. Mattress suture 2O are placed circumferentially around the margins of the posterior left ventricular free wall defect. Each suture is buttressed with the Teflon felt pledget on the endocardial side of the left ventricle. With all sutures placed, a circular patch fashioned from dacron graft is slid down into the epicardial surface of the left ventricle. Then additional pledget or Teflon is placed under each suture, as it's tied to cushion the tie and prevent the cutting through the friable underlying muscle. So again, cross-sectional view of complete repair of posterior VSD with the patch. For endocardial repair of posterior VSD rupture using a technique of the part exclusion. An incision is made in the inferior wall of the left ventricle, 1 or 2 millimeter from the posterior descending artery, starting from the midpoint of the inferior wall and extended proximally toward the mitral annulus and distally toward the apex of the ventricle. Care is taken to avoid damage to posterolateral papillary muscle. Then a bovine pericardial patch tailored in a triangular shape. The base of triangular shape patch is sutured to the fibrous annulus of the mitral valve with the continuous 3O Prolene suture, starting at the point of corresponding to the level of posterior medial papillary muscle and moving medially toward the septum until the uninfarcted endocardium is reached. Then the medial margin of the triangular shape patch is swung to the healthy septum endocardium with a continuous 3O or 4O Prolene. The lateral side of the patch is sutured to the posterior wall of the left ventricle along a line corresponding to the medial margin of the base of the posterior papillary muscle. At this point, it is usually necessary to use full thickness bites and anchor the suture on the strip of pericardium or Teflon felt applied on the epicardial surface of the posterior wall of the left ventricle. Once patch is completely secured to the mitral valve annulus, the endocardium of the interventricular septum and the full thickness of posterior wall and the ventriculotomy is closed with 2 layers of full thickness sutures buttressed on strips of pericardium or Teflon. And the impacted right ventricular wall is left undisturbed. For the recurrence of VSD, using echocardiography, recurrent or residual septal defects have been observed to occur in 10 to 25% of patients. Large residual septal defects with a QS more than 2 should undergo a repair, while smaller defects may be managed medically and may occasionally close spontaneously. Percutaneous approach for those small residual defects have been preferred when possible, and surgical closure of a late post-operative particular septal defects have been reported via a right atrial approach. Causes of death post-repair, most commonly low cardiac output, followed by technical failure, bleeding, sepsis, recurrent infarction, and CVA and arrhythmia. My resources was Lawrence. Any comment, Dr. Amalin?
No, thank you very much. I think you covered it very well. Again, it's very important to recognize that VSD is associated with high mortality. And the debate is when to operate is still ongoing, whether we should wait or we should proceed to the OR. And general recommendation is to proceed to the OR even if the patient is stable to avoid any complication. And exclusion technique is the gold standard technique right now in both anterior and inferior VSD. I would just add one thing. Those who did not attend my session last week, I would recommend you guys go back and check, because in my I covered the 3 mechanical complication post-MI, including images. It's very important as it's very rare pathology right now, and we don't often see, is to be able to diagnose the VSD in the angiogram or in the echo, also to differentiate between true versus pseudoaneurysm, because it's completely 2 different management approach. In pseudoaneurysm, you want to operate as soon as possible. However, in true aneurysm, you may wait a little bit. It's a lower risk of rupture. So it's very important to be able to differentiate those in the echo. So if you came across an echo with aneurysm, you should be able to tell, because it's going to be your call whether to book this patient as a case versus to medically optimize and wait, and to think whether this patient actually had an indication to operate or not. In the true aneurysm, patient has to be symptomatic. However, in pseudoaneurysm, even if asymptomatic, patient need to be operated.
Okay, thank you, Abdullah, and I would like to welcome you, Dr. Mariam. Thank you for rising your time to join us. Any question from the audience? Okay, so we will be starting our next session at 1:45, inshallah.
السلام عليكم. Good afternoon. Let's start.
Walaikum assalam. Yes, Dr. Walid, please go ahead.
Okay, excellent. The slides clear?
Yes.
Okay. Okay, so today, inshallah, we'll be talking about carotid artery disease, specifically in patients requiring CABG. The majority of the presentation is going to be talking about the interaction between these two pathologies and not focusing on one or the other. So, CABG, you all know that CABG is probably not only one of the most, but probably the most procedure that we do. That's why the standard and the expectations out of this procedure is quite high. Now, people measure the success of CABG using multiple measures or outcomes. One of those is stroke, and it is probably one of the most important outcomes. Now, when you look into the risk factors of stroke in patients undergoing CABG, there are a lot of risk factors. One of them is coronary artery disease, which we will be talking more about it in the exact details. But if you look into the patients with coronary artery disease and see the percentage out of those that have coronary artery disease, that have carotid artery stenosis, they are around 22%. So 1 out of 5 patients who's going to be presenting to you for CABG, they are going to have coronary artery disease. Sorry, carotid artery stenosis. Now, there are some terms and some concepts that we need to discuss before we delve further into this presentation. When we talk about lesion severity and carotid artery stenosis, there are some grades. If you have lesion that is less than 50%, this is considered mild. 50 to 69, this is moderate. 70 to 99, this is considered severe. There are 2 extra terms, which are near occlusion or strength sign. This is mainly the radiological term. It's used to describe a very severe long segment of narrowing that extends from the bifurcation to the skull base. And here lastly is occluded or completely occluded. Another term that we need to define, which is very important, especially when you consider operating on this carotid artery stenosis, is symptomatic carotid artery stenosis. So what makes a person symptomatic? A person is symptomatic when he have neurological symptoms that have the following characteristic, which is mentioned here. First, that it's sudden in onset. Second, that it is appropriate inside. So if it's ipsilateral to the lesion or the carotid stenosis. And the symptoms that the patient will have, they include either transient ischemic attacks or clear strokes. Now, there's a question that arises: is vertigo or syncope considered part of these symptoms? Can any of our audience answer this question? Anyone?
Yeah, Walid, I think vertigo, I'm not sure, but syncope, I think, yeah, part of that.
Okay.
Yeah.
So you're not completely wrong, but when we talk about vertigo and syncope per se, especially when we talk about isolated carotid stenosis, they are not usually considered as symptomatic, and they are very rare causes of the carotid artery stenosis, especially when it's unilateral, is very rare cause of such symptoms. So that's why usually it's not considered symptomatic. So if you have a patient with these 2, you should look for another reason and not attribute it to the carotid artery stenosis. But obviously, I said that you're not completely wrong. If you have a patient with completely 2 occluded carotid artery you'll bust out. So other terms that you need to define, just I'm sure you all are aware of it, but for revision, what is the actual definition of stroke? This when you have acute neurological deficit that lasts longer than 24 hours. And this deficit needs to be caused by central nervous system malfunction or hemorrhage. Perioperative stroke, specifically in cardiac surgery, these are strokes that either occur intraoperatively or post-op around 14 to 30 days. There are multiple definitions, but usually this is the range. If you open any book of cardiac surgery, you see there are a lot of risk factors, especially for perioperative stroke during CABG. And carotid artery stenosis is usually one of the cited risk factors, but carotid artery stenosis in isolation, it has not been shown to be an independent risk factor, especially when you control for aortic arch atherosclerosis. So it's dependent on the presence of the arch. Now, this gives you a gray zone, especially when you're trying to intervene on this, especially if you think that the significance of it and on the risk of developing stroke. Now, there is a question at the end of the slide: what is the percentage of perioperative strokes that can be attributed to carotid artery stenosis, which we will answer in just 2 slides. But just revision of strokes, usually perioperative strokes occur in 2 mechanisms, either hyperperfusion, which usually manifests in watershed areas, or you have embolic. So this is a study that was done, and it utilized a criteria called TOAST criteria. This takes clinical and radiological findings to classify what is the cause of the stroke, whether it's embolic or it is hyperperfusion or ischemic in nature. In this study, they found that around 75% of patients, the source of the stroke, it was cardioembolic stroke, which, if you open any cardiac surgery book that talks about bypass, you always attribute majority of the strokes to emboli that occurred during the aortic manipulation or stroke or emboli from the circuit. Now, 13% was attributed to small vessel stroke or cerebrovascular disease. And only 5.3% was attributed to the large vessel stroke, which is the carotid artery. So you can see that only a very, very small, minute number of patients actually have strokes that is attributed to carotid artery stenosis. And especially if you consider that only 5% of our patients have stroke, 2 to 5, and 5% of those will have the stroke because of the carotid artery. So it's a very small number. So which patient which asks the question is which patient you're gonna really intervene. Now, this is showing that depending on the severity of your illness, what is your chances of having a stroke? And obviously, the more severe disease that you have, the higher the percentage of, or the higher your risk of developing stroke. Now, so how do you usually screen for carotid artery stenosis? Usually the modality of choice is duplex ultrasound. Depending on the center and their policy, some may screen all patients, some may screen individual patients. In our center, we usually screen all patients that are coming for CABG with duplex ultrasound. But if you go back to guidelines, actually before going to guidelines, if you look into the guidelines for general population, not the population, not our cardiac surgery population, US Preventive Service Task Force has recommendation regarding that. They recommend to do carotid duplex screening for patients who are symptomatic, as per our definition a few slides ago, or have carotid bruit, or they are older than 65 years old. In our guidelines, it's nearly similar. Screening all patients is not recommended, as shown in the last recommendation. And the people that you'd recommend, either class 1 if they have history of TIA or stroke within the last 6 months. 2B, if they didn't have, if they are asymptomatic, you'd only consider screening them if they were older than 70, if they have multivessel coronary artery disease, or they have lower limb vascular disease, or if they have carotid brewing. Now, there are pitfalls to using duplex ultrasound. It can fail in identifying certain stenosis, especially if it's near the skull, the base of the skull, or the level of the siphon, sometimes even near the origin from the base of the aorta. Another thing that it uses the flow velocity rather than actual diameter to classify stenosis. So it may overestimate the degree of stenosis if you have any condition that leads to increased flow within one of the carotid. For example, if you have contralateral stenosis, the flow will be higher in the other side, and this may overestimate the stenosis. Now, there was a question that was asked, or a point of discussion that we had in one of our teaching sessions in our center, the use of carotid ultrasound bedside, since if you're not going to screen all patients and you're only going to follow that, there's a middle ground. In a lot of centers, sometimes you can have the ultrasound machine in the ward or in the ICU, and maybe you can use it to perform a bedside examination. So looking into literature, there is only one study that looked into similar situation, which is use of emergency physicians of point of care ultrasound for assessing carotid stenosis. They found that if you compare emergency physicians examination with expert interpretation, and this is only eye estimate, it's not measuring anything, just eye estimate. They found only moderate agreement between the emergency physicians and the expert who interpreted the same images. But if you compare the emergency physicians' examination and their interpretation of the image with the gold standard, which is CT angio, they found poor. So it was low to moderate association. But one thing to consider is that a majority of that this study, it was done with visual estimate only and not using any and if you consider further training, maybe these results will improve. But as far as the study goes, probably if you do bedside carotid ultrasound, you will not be able to identify carotid stenosis consistently. So for the patient with carotid artery stenosis, which patients are you really going to intervene on? There are a few factors to consider: whether the patient is symptomatic or asymptomatic, the degree of the stenosis, and the number of vessels involved, which is 1 or 2. And the guidelines are basically revolve around that. So when we talk about asymptomatic patients, if they have anything that is more than moderate, you'd intervene. So patients with 50 and up to 90%, 99, you would intervene. Patients who are symptomatic but have less severe degree of stenosis or less than 50%, revascularization is not recommended. Now, the mode of revascularization, there are a lot of studies, and depending on the guidelines that you look, whether it's made by surgeon or medical people, you'll have different recommendations. Majority of the surgical guidelines, they lean toward doing carotid endarterectomy versus carotid artery stenosis. And when you look into the European Society recommendations, they recommend doing carotid endarterectomy. Now, for asymptomatic patients, generally it's not recommended to do any intervention, especially if they have isolated moderate to up to severe in one side. However, if your patient have bilateral disease of 70 to 99% of carotid stenosis, intervention is recommended. And if you have a patient with one vessel that is completely occluded and one vessel that is between 70 to 99, which is moderate and severe. Now, there are a subset of patients who have only one side with moderate to severe carotid stenosis that recommendations they recommend doing intervention on, who have these following characteristics, because they believe that these characteristics will increase your risk of stroke, and probably intervention is helpful in these cases. Some of them are clinical, so if you have contralateral history of contralateral TIA or stroke, or if imaging characteristics, depending on the imaging done for the patient. And these guidelines reflect what we just talked about. These are taken from the European Society of Cardiothoracic Surgeons. So if you decide to intervene on a patient, what is your approach for management? There are a lot of strategies that you can do. Either you can do combined or staged. So what's the difference between the two? Combined is basically doing both at the same setting. Staged is doing one or the other with different varying intervals. You can in stage you can either do the surgical intervention on or any intervention for that matter on the carotid, and then do it on the then do CABG, or the opposite, do CABG then the carotid artery intervention. In combined, there are a lot of approaches as well. You can do your carotid intervention before opening the chest. You can do it after opening the chest, but not on bypass, and lastly, you can do it on bypass. Now, to answer these questions, first, let's answer the question of whether do you want to do it combined or do you want to do it staged. And this is one of the studies that was done very long time ago in 1999, helping us in answering this question. They found that doing combined carotid endarterectomy with CABG has higher risk of stroke and death than staged procedures. So usually, these procedures, the combined procedures, have been always been very high risk. Maybe because of the procedures itself, maybe because of the patients that are chosen for that, which we will be touching on lastly, the last slide. Now, okay, so you decided or you figured that combined procedure is very risky for your patients. You probably want to do stage. So which one do you choose? Do you do the carotid intervention before the CABG, or the CABG before the carotid artery intervention? This is another meta-analysis. One thing to consider that all of these studies are only on observational studies. Nothing is randomized. Anyhow, this meta-analysis, they found that if you do the carotid intervention first before the CABG, logically you'll have higher rate of perioperative MI, and this is what is shown in the statistics. And if you do the CABG before the carotid artery intervention, you'll have higher risk of stroke. So with this, you can form an algorithm of choosing which patient goes to what. So, and this is one of the such algorithms that is found in STS Cardiothoracic ebook. So if you decide to intervene on your patients, so if you bypass all of these, because all of these, the consideration that we talked about before, which lesion is symptomatic? So if you have a patient who has a stroke, if the patient is not symptomatic from stroke, you would do the CABG first. Why? Because you want to avoid having higher rates of MI. We said that if you do CABG first, then carotid intervention, your risk of stroke is higher. But this patient, due to his status of being asymptomatic, is less risky. Now, if your patient is symptomatic from the stroke, then you think in your head that you want to do the carotid intervention first. But you need to look at also the coronary artery disease, whether it's symptomatic or not symptomatic. If it's asymptomatic, then you may consider doing a staged, which is carotid intervention, then CABG. However, if both lesions are symptomatic, then maybe you consider doing combined procedure. And this is what I meant by these procedures are usually high risk, because usually the patients that are reserved for such procedures usually have both lesions that are symptomatic, and these patients in themselves are very risky. So that's maybe one of the reasons why these procedures are high risk. Anyway, to summarize, basically you want to intervene on the symptomatic lesion first. If you have patients complaining of the carotid artery stenosis, you intervene on that first. If the patient has chest pain and symptomatic coronary artery disease, you want to intervene on that first, direct CABG, and then carotid artery stenosis intervention. Now, let's say that you decided, now there is a question that, now, okay, I am going to do CABG, but which one is better for my patient? Is it on pump or off pump CABG? This is a very small and I think one of the only, if not the only study that I found in such matter. There are a lot of issues with the study, but what they found is that the early outcomes after doing carotid artery stenosis and then plus off pump CABG usually is better than those either staged or combined procedures. And the rate of stroke that they found is around 1.6% compared to somewhere between 4 to 7, depending on the type of procedure that you were going to do on pump, whether combined or staged or reverse spaced. That's the last slide. Thank you, everyone, for listening, and I'll be glad to receive any of your questions.
Okay, so I just have anyone have a question, please go ahead. If not, I just have a comment, if nobody has any question. Okay, so I agree with the algorithm, Walid. Of course, whatever the patient is symptomatic from, you start with. The general guidelines is always to do the CABG first. If the patient is, however, the patient presented with acute stroke, you would address the stroke first, and vice versa. If it's a patient is presenting with STEMI, you would do the CABG first and then the carotid endarterectomy. If the patient presenting with both, meaning acute stroke plus and STEMI or STEMI, you would do combined, knowing that it increase both stroke and perioperative MI. Now, if you would do the carotid endarterectomy first, you would have to consent the patient for higher perioperative MI. If you would do the CABG first, you would consent the patient for a higher risk of stroke. So just you have to know the incident of stroke in both procedure. Now, if you decided to do a combined carotid endarterectomy and a CABG, any one of you have encountered or seen this procedure done before? So I'm just asking about the timing. You're in the OR, the cardiac surgeon is there, the vascular surgeon is there. Who would lead, who would start, which procedure is done? Because it's impossible that the cardiac surgeon and the vascular surgeon will be standing in the same way and like in the same table performing both operations. So one of them had to relatively start before the other. Do you guys have any idea of who's going to start first?
So, Dr. Mariam, I didn't attend such a situation before, but I know that we have 3 situations. So either you open the chest and before cannulation, they do the endarterectomy, the vascular surgery team.
Yeah.
Or they do the endarterectomy first and then we start. Or then, what else? Both endarterectomy and the CABG on pump both. This is what I know.
So endarterectomy and bypass at the same time is impossible, because just think about the OR table. The surgeon, the cardiac surgeon, and the assistant will be standing on the both side of the table, right? So where would the vascular surgeon be standing? So it's impossible. So you'd have to have timing of them, or like an agreement. You come to the OR, vascular surgeon will be there. So you have to have a logic agreement of who's going to start and what we're going to do first.
What I know is that they do the endarterectomy, the usual one, the endarterectomy first, and then we open the chest, they do the endarterectomy, and then we cannulate.
Okay, do you know why they do this?
Well, maybe the incidence of stroke, I'm not pretty sure.
No, it's mainly
because of heparinization.
Excellent. Who's this? Amjad?
This is Amjad.
Okay,
Yes.
so yeah, so what's your thoughts about it?
Yeah, so the vascular will start first, do the endarterectomy, leave the wound open, and then the sternotomy, bypass, and after giving heparinization and graft, harvesting the lima, then we'll give heparin, and there we can close the wound as well.
I totally agree with you. Excellent. This is the logic thought of it. So they will do the endarterectomy. Maybe if there's any vein harvesting, they can do the vein, but you can't open the chest. They will do the endarterectomy. They're done. They'll pack the wound. They will not close the neck. Okay, we'll come as a cardiac surgeon. We'll do the operation total. And after we give a protamine and we'll close the chest, we will cause the vascular surgeon to come and close their wound in order to prevent neck hematoma and bleeding. So they will not close, they will pack, they will leave their wound open. We'll do our procedure. Once we're closed, everything done, we'll call a vascular surgeon to come and close the wound.
Dr. Mariam, I have just one question. I was thinking, what if we open the chest and then the vascular surgeons, my logic in opening the chest first, just in case anything happens after when the vascular surgeons are doing
you can.
to the carotid?
If the patient is high risk, you want to open and just leave it there, but you're not going to give your full. Vascular will give heparin, but their heparinization is only 10,000, right? Not like ours. So they will give very limited heparin to do the endarterectomy. Your assistant can take the veins and the radial. If they're working on the left side of the table for the endarterectomy, you may start taking the mammary. I think it's very difficult too, because his assistant will be on the other side of the table. So you let them do the procedure. The chest is open or closed. It's really depend on the patient hemodynamic stability. And then once they're done, you will make sure that you communicate with them. Please do not close your wound. Just pack it and leave it. We're going to give our heparin, which is like triple the heparin that they already gave. We'll do our procedure. We'll give protamine. We'll do hemostasis. We'll close our chest. And then we will call them or page them to come and close their wound. Okay, so this is because if you guys putting in this situation and the vascular is there, you will find it awkward, like who's going to start. The tables they can't afford all the people around. So this is the logic. Okay. So I remember a case, like I was scrubbing a case like this. So it was me. And after that, I paged the vascular surgeon, the resident, to come and close the neck. And then I was like, the argument was, who's going to transfer the patient? Me or you? Whoever finished last, going to transfer the patient. That's just a joke, okay? So it was between me and...
Was it the issue that you were arguing about? Is it
No, just a joke. After I've done and I closed the chest, I called the vascular resident to come and close the neck, right?
Yeah.
Okay, and I was like, okay, I finished first. I'm gonna go home and you transfer the patient.
Yeah.
Patient now. It's just a joke, right? But just like one of the things that. Okay, so that's one of the things that you have to keep in mind.
Okay, thank you, Walid, for your presentation. Thank you, Dr. Mariam, for your point. Is there any other comments or any questions from the audience? Great, thank you. So, what about having 10 minutes break and then we can resume for the stitch trial? Okay, so now it's 2:15. We will resume as of 2:25. Okay, Dr. Fatma, once you're ready, you may start. Thank you.
Okay. Good day, everyone. Today I'm going to present the STITCH trial, which is the surgical treatment of ischemic heart failure. This study was published by the New Journal of Medicine in April 2011, and it was sponsored by the National Heart, Lung, and Blood Institute and the National Institute of Health. So as a background information, it is estimated that 5.8 million patients in the United States and 15 million in Europe have heart failure. Coronary artery disease is the most common substrate for heart failure in industrialized nations. The major long-term manifestations of coronary artery disease and LV dysfunction are projected to affect 8 million patients by the year of 2030, which has enormous societal implications. In previous clinical trials, patients with chronic stable angina were randomly assigned to undergo CABG or receive medical therapy alone. Those led to recommendations supporting the use of CABG to relieve disabling symptoms of angina, particularly among high-risk subgroups with extensive coronary artery disease. However, these trials excluded patients with severe left ventricular dysfunction, in which the ejection fraction was less than 35%. So the importance of the STITCH trial was to evaluate the role of cardiac surgery in the treatment of patients with coronary artery disease and LV dysfunction. A major hypothesis of the trial was that CABG plus intensive medical therapy based on current guidelines, as compared with medical therapy alone, would reduce mortality. Results of the STITCH extension study would be also demonstrated in this presentation. So the STITCH trial showed that in patients with ischemic cardiomyopathy, coronary artery bypass surgery and medical therapy resulted in higher mortality rates at 30 days, but with a significant improvement in long-term mortality in 2 years, results compared with medical therapy alone. So the study design, it was a multi-center, non-blinded, randomized clinical trial that was conducted between July 2002 and May 2007. It was conducted at 127 different clinical sites in 26 countries. It has a follow-up duration with a median of 5 years for hypothesis 1 and 4 years in hypothesis 2. It included around 2,112 patients who were enrolled in the overall STITCH trial. There were 2 hypotheses. 1,212 patients were enrolled in the first hypothesis, and 1,000 patients were involved in the second hypothesis, which compared CABG and surgical ventricular restoration to CABG alone. The inclusion criteria involves the adult patient with left ventricular ejection fraction of 35% or less, measured by different imaging, and which were valid within 3 months of the trial entry, and patients with coronary artery disease suitable for revascularization. The exclusion criteria involves the failure to provide informed consent, aortic valvular heart disease requiring valve repair or replacement, a history of more than 1 prior CABG, a cardiogenic shock within 72 hours of the randomization, a plan for percutaneous intervention for coronary artery disease, and recent acute MI, judged to be an important cause of LV dysfunction within 30 days. Also, patients who were not suitable for surgery, non-cardiac illness with a life expectancy of less than 3 years, or imposing substantial operative mortality. Another criteria for including the patients, patients were eligible for medical therapy alone if they didn't have a stenotic lesion leading to loss of 50% or more of the diameter of the left main coronary artery, and if they didn't have Canadian cardiovascular score class 3 or 4 angina while receiving medical therapy. And patients were eligible for surgical ventricular reconstruction if they had dominant anterior left ventricular akinesia or dyskinesia. So the primary endpoints were in hypothesis 1, all-cause mortality, and hypothesis 2, long-term survival free of cardiac hospitalization. Secondary endpoints for both hypotheses: cardiovascular mortality, all-cause mortality, and CV hospitalization, cost effectiveness and quality of life for each treatment, exercise capacity, 30-day mortality, cardiac hospitalization, non-cardiac hospitalization, MI, and stroke. So for the procedure, on the basis of the earlier discussed eligibility criteria, the patients were assigned by the enrolling physician to one of 3 trial strata. Stratum A included patients who were eligible for either medical therapy alone or medical therapy and CABG. For stratum B, it included patients with the 3 treatment options. Stratum C included patients who were eligible for either medical therapy plus CABG or medical therapy plus CABG and SVR. So as a result, all patients in stratum A and some of the patients in stratum B were randomly assigned to either medical therapy alone or medical therapy and CABG, the first hypothesis for STITCH trial. For the second hypothesis, it included patients in stratum C and some of the patients in stratum B. Then a lead cardiologist at each center was responsible for recommending the most appropriate medications and devices for the treatment of heart failure and coronary artery disease on the basis of the current guidelines. The adherence to treatment guidelines was emphasized in the care of all patients and was monitored by a medical therapy committee. Cardiac surgery was performed also by surgeons who had performed CABG in at least 25 patients with an ejection fraction of 40% or less, with an operative mortality rate of 5% or less. Then for the follow-up, all patients underwent follow-up evaluations at the time of discharge or at 30 days, every 4 months for the first year, and then every 6 months thereafter. The median length of follow-up was 56 months, and with a minimum of 12 months and maximum of 100 months of follow-up. So talking about the first hypothesis for the STITCH trial, patients in both groups, the CABG and CABG plus medical therapy, have almost similar baseline demographic and clinical characteristics. Also, they have a balanced baseline characteristics in regarding the ventricular function and the coronary anatomy. Also, the medication use was almost similar in the 2 groups. Comparing the study outcomes for the first hypothesis, for the primary outcome, there was no clinically significant, statistically significant difference between the 2 groups, the medical and the CABG, in regard to the primary outcome. However, the secondary outcome, which is first the mortality after 30 days, it was higher in CABG group than the medical therapy alone. However, all the other secondary outcomes were higher in the medical therapy. Here's the Kaplan-Meier representing each of the outcomes that we have discussed in the table. So first of all, the primary outcome, which is the mortality, all-cause mortality. As we said, there is no significant difference between the 2 groups, the CABG and medical therapy. For the death from cardiovascular causes, again, it was the rate of death was higher in the medical therapy group. Again, the death from any cause or hospitalization for cardiovascular causes, the mortality was also higher in medical therapy. Then we have 2 types of analysis that were done after 1 year from the randomization, comparing the primary outcome in both groups, the CABG and the medical therapy. It shows a statistically significant difference in regard to the primary outcome, which is the mortality from all cause, favoring patients who were in CABG group. Those patients in CABG group involved who were initially randomized to the CABG group, or the patients who had a crossover from the medical therapy to the CABG group. It shows a higher mortality rate in patients with the medical therapy in comparison to the CABG. Then also at 1 year, we have a per protocol analysis comparing the 2 groups in terms of the primary outcome. Also, it showed higher mortality with the group receiving medical management only. Also for a STITCH trial, for hypothesis 1, they had another subgroup analysis. The first one was in terms of the myocardial viability. It includes around 601 patients, dividing almost 300 in the medical group and 300 in the medical and CABG patients. So the results showed that patients with viable myocardium were more likely to survive, irrespective of the treatment strategy. The unadjusted analysis, however, in the adjusted analysis, there was no statistical significant difference between the 2 groups in regards to the viable myocardium. It didn't affect the result or the rate of mortality. The second subgroup, which was involved in this study, was the mitral regurgitation. It involves around 195 patients. In the medical therapy arm, increasing severity of MR was associated with increased long-term mortality at 5 years, and this might also represent the severity of the disease in general. In the CABG, patients that underwent concomitant mitral valve surgery had a significant reduction in the long-term mortality as compared with those who didn't have the MV surgery. Now we'll discuss the 10-year results for the STITCH extended study. For hypothesis 1, the primary outcome, which is the all-cause mortality, there was a significant difference between the two groups. The all-cause mortality was higher in the medical therapy. The cardiovascular mortality was also higher in the medical therapy, and all-cause mortality, or MI, again, higher in the medical therapy in comparison to the CABG group. Here we have the Kaplan-Meier's, the same result discussed in the table. The first one, death from any cause, which is the primary outcome. We can see like higher rate of death with a medical therapy after the 10-year duration of the follow-up. Death from cardiovascular causes, again, the rate is higher in the medical therapy, clearly statistically significant difference. Death from any cause or cardiovascular hospitalization, also higher in the medical therapy. Here, this model shows some interaction between the baseline characteristics and the primary endpoint, the primary outcome between the two groups, the CABG and medical therapy. So taking the example of the age, here we can see that CABG had a better survival rate in younger patients. However, for older patients, there was no significant difference, which means that the survival rate would not be like as clear in older patients in comparison with the younger patients, and the two strategies, the CABG and the medical therapy. Another example is the severity of the coronary artery disease. As you can see here, with patients who had pre-vessel coronary artery disease, they would have a better survival with CABG than with medical therapy. Okay, so now I'll discuss the results of the second hypothesis. There was no significant difference in the baseline clinical characteristics between the two groups, the group with CABG and the other with CABG and SVR. Except for the arterial conduits, they were more commonly used in the group with the SVR. The SVR added a median of 27 minutes to the cardiopulmonary bypass time during the procedure. A greater reduction in the left ventricular end systolic volume index was observed in the SVR group. And as a conclusion for this hypothesis result, there was no significant difference in the primary endpoint of death and cardiac hospitalization between patients who had SVR or the patients who had CABG only. The quality of life for with the groups CABG versus the CABG plus SVR, there was no significant difference between the two groups in regards to the quality of life. However, the SVR was somewhat more expensive or more costly than the procedure of CABG alone. So based on these results, routine SVR at the time of CABG should not be recommended at the time being. So reaching to the conclusion, the STITCH trial compared medical therapy alone with medical therapy plus CABG in patients with coronary artery disease and LV dysfunction. There was no significant difference between the two study groups with respect to the primary endpoint of the rate of death from any cause. The rates of death from cardiovascular causes and of death from any cause or hospitalization for cardiac causes were lower among patients assigned to CABG than among those assigned to medical therapy. The study has some limitations. The trial didn't detect a significant difference between the treatment groups with respect to the primary outcome. However, there was a clear difference between the two groups in regard to the secondary outcomes. Given the results of the other secondary analysis, the lack of significant difference between groups and the outcome of death from any given cause was more likely to have been due to limited power or limited duration of follow-up. So initially for this study, they suggested a follow-up of only 3 years, then the follow-up was extended to 5 years, as we stated clearly in the beginning of the presentation, than to a true lack of benefit of CABG. The trial was not blinded and could not realistically be blinded, so the non-fatal outcomes could have been influenced by the clinician's knowledge of the treatment the patient received. Yes, just like an analysis for the study in general. The question, it was an important study that impacted the coronary artery disease and LV dysfunction management. The design, it was international, multi-center clinical trial. Sample size was acceptable. Significant difference in the primary endpoint was achieved with extended follow-up duration only. The conclusion was appropriate to the study result, and the applicability, I think it would play a role in the decision-making process in the future. Thank you.
Thank you, Fatima. Any question from the audience or comments? No questions. Dr. Mariam, could you please comment or?
Yeah, absolutely. So when we read any randomized trial, right, the big question is, in any study, when we study it, what did I learn from the study? How did this study would affect my practice? So any of you has thought about it? Like if we have patient who's coming for coronary artery disease, like for a bypass surgery, and has a significant LV dysfunction, which is ejection fraction less than 35%. How do you think this study would affect your practice? Would you do CABG, or would you do a medical treatment alone and tell the patient, well, there is no significant difference and CABG will not improve your survival, giving you your significant LV dysfunction?
Dr. Mariam, you may choose who you want to answer.
Okay, no volunteer as usual. So I just want to remind you, like one day I was a resident like you, and we have done a lot of journal clubs. And one of the sessions that I presented when I was a junior was the STITCH trial. Exactly. I was, I think, R2 when I presented in a journal club, and I summarized it very well, all the outcomes, everything, and I presented very well. And at the end of the presentation, my program director asked me this question. Okay, so what did you learn from the study? And how would this change your practice? So since then, I was very embarrassed because I could not answer the question at that time. But since then, whenever I read an article, especially a randomized controlled trial, I would ask my question, those two questions. What did I learn from the study? How would this affect my practice? Would I use it to convince my patient? Is that an evidence, is a strong evidence to use? And the third question is, how is this in line with the general guidelines? Did this study affect or change the guidelines or no? Any of the R7? Do you guys have any idea, or could any of you answer one of the three questions?
Okay, I will be the volunteer, Dr. Mariam, if you allow me.
Absolutely.
Now, for the first question, whether this study will change my practice, it will add to my practice. Mm-hmm. Yes, I will counsel the patient if I have a patient who is having reduced ejection fraction below or equal to 35, knowing that it is very high risk. Now, in this study, and if you dissect in the STITCH trial, you will find that in their exclusion criteria, they wrote that they eliminate high risk patients where it is not defined.
Yes.
And this is will reduce the power of the result of the study. But overall, yes, in long term, this is the only take that I can have. Now, the long term would be better with CABG compared to only medical therapy. Now, but this is not a solid, to me, is not a solid information. In regards to the change of guidelines, I think in 2014, they added to heart failure recommendation, heart failure patients with coronary artery disease as a class 2B to go, if the ejection fraction is less than 35, to go for CABG. So this is what I can say.
Okay. I wish if Dr. Khoguer was here, he would be very proud of your answer, Mohammed. So yes, so I've learned from this study is that it's a very solid study. It will affect my practice. From the conclusion of the study, I've seen a survival benefit of CABG plus medical therapy over medical therapy alone in patients with reduced ejection fraction. In the guidelines in 2014, it was still 2B for patients with reduced ejection fraction less than 35%, because at that time, the 10-year result of the STITCH trial was not published. The 10-year result of the STITCH trial was published in 2015. And since then, 2015, I was a PGY1. So since then, I was like waiting for the guidelines to be changed. 2016 came, 2017, no change, 2018, 2019, 2020, 2021, until I wrote my exam, the guideline hasn't been changed. So even in my note for my exam, every time I come across the guideline and I see ejection fraction, CABG with ejection fraction less than 35%, I put a big question mark. I'm asking myself why the guideline hasn't been changed, right? In line of the 10 years outcome of STITCH trials. However, in 2021, it has changed to a class 1 indication. If you guys can remember, I'll share my screen and show you. Okay. Where is it? So this is the 2021 guidelines for patients with left ventricular dysfunction and multivessel coronary artery disease with ejection fraction less than 35%. It's finally class 1 indication, finally. Despite the articles was published in 2015, but it hasn't made its effect until the 2021. So right now, you guys, like even though the guideline hasn't been changed from 2015 till 2021, every time when I came across patient with reduced ejection fraction, I'll be very strong in advocating for this patient to go for CABG. And I was like saying, yes, there is a survival benefit for a CABG induced patient. But right now, finally, we have it as an evidence in the guidelines. Okay. So that's what we have learned. So if you're going to answer your question, what I have learned, I've learned that survival benefit is ensured with reduced ejection fraction. How it changed my practice, I will encourage patient and advocate for them to go for a bypass surgery. And how is that affect, or how is that in line with the current guidelines? Till 2021, it was class 2B, but now it's a class 1 indication. Do you guys have any questions?
This is very enlightening. I missed this new recommendation. Thank you, Dr. Mariam.
Absolutely. Now I have another comment about the STITCH 2 trials. Okay, Fatma, you mentioned that in the STITCH 2 trials, if you can go, I'm not sure if you can, like if you go back to your slide, but when you said the primary endpoint, which is all-cause mortality for those patients who underwent SVR versus no SVR, there was no difference in mortality. And for the secondary endpoint, they looked at the left ventricular end-systolic volume index. And there was significant difference in terms of the volume of the left ventricle for those patients who underwent the systemic ventricular reconstruction. However, it did not translate into a survival benefit. So what I will add into this here, if you go back to the study, I opened it here. So this is the STITCH 2 trials. When they looked into, you guys can see my screen?
Yes, Doctor.
Okay, so when they looked into the left ventricular volume, so the mean end systolic volume index in patient assigned to undergo CABG alone, okay, they decrease it by 5 ml per meter square, which is usually they decrease it from 82 to 77 ml per square meter. okay, as a reduction of 6 ml in patient who had only a CABG. For those patients who had underwent CABG plus SVR, they decreased the left ventricular insystolic volume by a mean of 19%, which means they decreased it from 83 to 67 ml per meter square. When they did, so knowing this did not affect the survival, they did actually another study. It's called an insight from the STITCH trial. That's a trial. It's inside from the STITCH trial, change in the left ventricular size after coronary bypass graft with or without surgical ventricular reconstruction. And what they found in conclusion, that a survival benefit was realized compared to bypass alone if you achieve a postoperative end systolic volume index of 70 ml per meter square or less. If you have not achieved this, there will be no survival benefit. And there is also a lot of another studies came later to further studies this criteria. And this is one of them. Sorry, I don't know how to decrease this. Yeah. So end systolic volume following surgical ventricular reconstruction impacts survival in patient with ischemic dilated cardiomyopathy. So what they found actually that left ventricular insystolic volume index is a predictor of survival following SVR. Lack of additional improvement in survival SVR observed in the STITCH trial might be due to inadequate volume reduction. Okay, and then what they noticed that patient with postoperative left ventricular insystolic volume index more than 60 ml per meter square, it was independent predictor of mortality. So if you have that big ventricle, the mortality will increase. However, if you achieve LV insystolic volume index less than 60 ml per meter square, the survival benefit will show here. Okay, so yes, the STITCH hypothesis 2 did not show any survival benefit, but because they did not perform the SVR adequately and they did not decrease the LV ventricular systolic volume index to 60 ml per meter square. If you do this, or at least to 70 ml, you would notice a survival benefit. So that's one of the criticism about the hypothesis STITCH 2 trial. Okay.
Yes, Dr. Maria, thank you. You know, Doctor, if I can ask, you know, I didn't see anyone who is advocate to go for, you know, ventricular repair or restoration.
Sorry, Mohammed, can you repeat your question again? I didn't hear you.
Now, the systolic, the ventricular repair or restoration.
Yes.
How does that can be achieved?
It's exactly done by the Dorff technique. Now let me try to. Sorry, but this is my note from the exam. But 1 second. I'll try to, because I have it. I'll try to circulate the article as well.
I'm not sure if it's showing. The only thing here we can see, or what I can see, the AHA recommendation.
So you don't see my screen?
We see the screen. But it is, I think, lagging on the recommendation slide.
Okay, 1 second. How about now? Do you see it now?
Yeah, we see the slide, same slide that you showed
okay,
at the
because
beginning.
your screen sharing is paused. I don't know why. Resume sharing. You are sharing the screen. How about, I don't know. Every time I go to this, it won't. That's strange.
Dr. Maria, maybe you can, when you click share screen, share, you can. There are multiple choices. You can choose the PowerPoint or the screen, or.
Oh,
so
I see. Okay.
Maybe you can choose the screen.
Sharing. Okay, I'll stop sharing and I'll share again. Share screen. Okay, desktop. How about now?
Yes, Dr.
Okay, so I'll share with you this this paper. It's called the DOR procedure, and this is how they use for the left ventricular aneurysm, true aneurysm, and to do the SVR in patient with dilated left ventricular dilated cardiomyopathy related to coronary artery disease. So what they do, if you see the aneurysm, they open a longitudinal incision a few millimeters away from the LAD. After that, they resect all the aneurysmal part or the scar tissue. Okay, some of them, they do a cryoablation at the edge of the scar just to decrease the risk of arrhythmia. Some of them, they don't. And then they do, remember the purse string, which is like a stitch around the opening. Before they tighten the suture, they inflate a balloon. It's called the door balloon. I don't have the picture of it, but I'll send you guys. I'll make sure I send you the article. So it's like a balloon, like, you know, the balloon they do it for the TAVI. They will insert it inside the left ventricle to a specific volume, which is left ventricular insystolic volume index 60 ml per meter square, according to the patient body surface area. So you'll calculate it, okay? And then you'll put it inside, and then you will tighten your suture around it to make sure this is the left ventricular size. After that, you will tighten, you will deflate the balloon and remove it. And then you close the incision either with circular patch or with the 2 Teflon. This is the other procedure done. See, this is the purse string done, and then they close it with 2 Teflon patch, okay? The most important things is that you reach the aim to left ventricular insystolic volume index less than 60 ml per meter square. As I mentioned, if you are in an institution, they don't have that specific balloon, you can use it with a gloves. So you just fill a gloves with 60 ml per meter square, according to the patient body surface area of saline. You put it inside the left ventricle and you tighten your purse string around it. And after that, you just bring a needle, purse that glove, and remove it. Okay, so this is called the door technique. As I said, they use it for the SVR and for the true LV aneurysm.
Yeah, it's clear.
Clear
Thank
now?
you. Yeah, it's clear.
So in the STITCH trial, they did not use this. It was random. They just like open, they resect the aneurysmal part and they close. So by the end of the procedure, they did an echo assessment to look at the LV insystolic volume index, but it wasn't planned in the OR, so it was random. And that what they noticed, that, you know, some surgeon will be more aggressive in their resection of the aneurysmal part, and some of them will be more restrictive. So that's why it did not show any survival benefit. But if you aim for that number, multiple study has shows that increased survival benefit would decrease the LV systolic volume index to that number. Do you guys have any questions?
Okay, if there is no questions and no more comments from your side, Dr. Mariam, you may start at your own time.
Okay, so if you guys don't want to break, we can go ahead very quickly with the freedom trial. I will try as much as possible to make it more interactive, or like, you know, without a lot of scientific words, okay? Just to make it friendly. You guys are okay to start?
Yes, of course.
Okay. So today we will do or discuss the freedom trial, which is a strategy for multivessel revascularization in patients with diabetes. Okay. So and first of all, before we start, why did we conduct that study? Do we think in our, you know, from our insight that a CABG is better than PCI in diabetic patient? Why do we think its CABG is better than PCI in diabetic patient? How would you convince you know, the hospital or whoever the institution that you want to do this study and you want that fund or a grant to do that study? Okay, so just for the sake of the time, I know it's We know that diabetes mellitus is diffuse, and it's a diffuse disease affecting multi-segment. So as you notice in patient with the diabetes mellitus, patient will have multi-segment disease in the coronary artery disease rather than a focal disease. So if you come and do, for example, a PCI or a stent, you may be able to stent the more significant lesion, but you will leave the more distal stenosis unrepaired. Right, so that by time it will progress and it will cause an NSTEMI or an occlusion. However, if you do a bypass, you're bypassing all that segment with your conduit and the blood flow relatively to all the coronary. Okay, we know it's also it's systemic inflammatory proliferative prothrombotic disease, which by definition, it's a progressive disease. Again, it will explain the first point by that the disease will be progressive. So if you don't bypass all the segment, you will encounter another problem. Okay. The other things is PCI are prone to stent or in-stent restenosis, which is increased risk of repeat revascularization, and we have seen it with all the studies, Syntax and all the coronary bypass trials, that bypass has increased risk of repeat revascularization, and basically, again, because it's progressive disease, and once you do the stent, that will not prevent the atherosclerosis to invade the stent and to progress on time. In contrast to coronary bypass surgery is more prone to complete revascularization. You can put your graft, you can choose to where you put your graft, and you can do as much possible bypasses in contrast to PCI, where you'll be limited to the most significant part where you put your stent in. Okay, so that's in general why we think CABG is better than PCI in diabetic patient. History-wise, there was a small study called the Barry trial. It was published in 1997, which shows patients with multivessel disease assigned to CABG or PCI. They followed them for 5 years, and they shows no difference in mortality in general. However, when they did a subgroup analysis for the diabetic patient, CABG had a longer survival. Okay, this study was a very small study. It was not powered to indicate that diabetic patient has a better survival with CABG. It's just only an observation in the subgroup analysis. That one of the things that opened the people's mind about doing or conducting a more better study to look into this issue. Okay, this, although it was a subgroup analysis, had led to the change in the guidelines and recommendation, and CABG was preferred for revascularization for multivessel disease in diabetic patients, but it was not a class 1 indication, but it was class 2B indication. Okay, and that was before 2015. Freedom came, and it was published in 2012, and it was a prospective randomized multi-center superiority trial that compared multivessel PCI to CABG in a patient with diabetes in optimal medical therapy. And it's very important to mention this, that those patients who both went to PCI or CABG were in optimal medical therapy, and there they were randomized to either a PCI or CABG. Okay, it was 2-arm study, superiority study, as we said. It's unblinded. The total duration was 7 years, but the minimum was 2 years. It was 140 sites worldwide were participating in this study. Okay, patient selection, the patient has to have a multiple vessel disease. They have to have at least 70% in 2 or more of the coronary artery disease, and indication of revascularization based on the symptom of angina or evidence of myocardial ischemia and the ACG. Diabetes, both type 1 and type 2 diabetes were involved. The criteria to be involved, you have to have a blood sugar, fasting blood sugar more than 120, or random blood sugar more than 200, or you have a pharmacological or non-pharmacological treatment, and you have to be in a pharmacological or non-pharmacological treatment for diabetes. Okay. The exclusion criteria, any patient who had a bypass surgery before or a valve surgery before were excluded. Any patient with left main disease were excluded. ST elevation MI within the first 3 days were excluded. Any patient with a prior PCI within 6 months were excluded. Otherwise, all other patients were included. Okay. For PCI, all patients receive a drug-eluting stent. Okay, and majority they use 60% use drug-eluting stent. It's called sirolimus, which is a second generation stent, drug-eluting stent, and the 60% use paclitaxel, which is, sirolimus is the third generation, and paclitaxel is the second generation drug-eluting stent. It's the same stent that was used for the SYNTAC trial. Sirolimus is better in terms of the drugs, and they believe that it has a better longevity compared to the second generation drug-eluting stent, but they use it in 40% versus 60%. But again, all of them had drug-eluting stent. Okay, aspirin and Plavix were used for at least 1 year for all patients. CABG, they encourage arterial revascularization when able. In terms of medical therapy, they were very optimized. Statin were very controlled. Blood pressure was controlled. Hemoglobin A1C was also controlled. Okay. So just to give you an idea how good they optimize the patient and randomize them. The primary endpoint was very easy: all-cause death, non-fatal MI, non-fatal stroke. Okay. Secondary endpoint was all adverse cardiovascular and cerebrovascular event. Okay. They managed to find almost 30,000 patients eligible for the study. And then they screened, 30,000 patients. They found 3,000 were eligible, but they only enrolled 3,000 patients, from 30 to 3,000. 1,900 were consented for the procedure, for 900 for CABG, 900 for PCI. Okay. So this is a big observation, from 30,000 to 1,900 that were enrolled and consented. For the patient criteria, almost 70% they were stable coronary artery disease, but they did involve patients with acute coronary syndrome. And this is very important to notice as compared to the SYNTAC trials, because the SYNTAC trials were all stable ischemic heart disease. Okay, so we could not, as I told you, patient PCI versus CABG and acute STEMI was not, you can't use SYNTAC trial to say CABG has advantage over PCI in a STEMI patient, because they were not involved in the SYNTAC trial. In the FREEDOM, they were involved. The 30% of them had acute coronary syndrome. Majority have non-ST elevation, but there's 20% had actually STEMI or acute MI, but 3 days after. They did not randomize them freshly, but they waited 3 days and then they randomized them. And we know why, right? We know that if we operate and do CABG and acute STEMI on day 1, they have high operative mortality, as we discussed a few weeks ago. However, if you wait 3 to 4 days, the preoperative mortality will decrease. And that's why the reason they waited for 3 days in those patients, okay? In terms of the other criteria, only 4% were type 1 diabetes. Majority were type 2 diabetes. So again, for generalization, if you have patient with type 1 diabetes, it's coming for coronary bypass, you can't really use the FREEDOM trial to convince him that your outcome would be excellent or your survival would be good, referring to the FREEDOM trial, because only 4% of them were enrolled. This is just to show you the preoperative mortality here. The data for blood pressure, the LDL, HDL, and they were all over controlled. Preoperative or for medication, aspirin, 90% of them had aspirin, either those patients who underwent CABG or PCI, 82% they were on statin, and 64 were an ACE inhibitor. Now, for the number of disease, 98% had LAD. So almost like it's like as a rule, patient has to have an LAD disease to be enrolled. And majority have a 3-vessel disease. Only very few, 0.1%, it was only 1-vessel disease. Majority were 3-vessel disease. So it's a multi-vessel coronary artery disease, not a single coronary artery disease with diabetes. In terms of ejection fraction, 90% has a preserved ejection fraction. However, they did involve reduced ejection fraction, very only like almost 10%. But again, this is another things to keep in mind, that there were stable patients with a preserved ejection fraction. In terms of the complexity of the coronary artery disease or SYNTAX trials, majority were intermediate score, 22 to 32. 35% were involved in SYNTAX score less than 22, and 20% were high SYNTAX score, but majority were intermediate. But they did not exclude high or low SYNTAX score from this trial. Okay, this is the patient characteristic. Looking at the p-values, skim around it, all non-significant. So that will give you an idea that it is very well a match between the two groups and there was no bias. Okay, when we come to the Kaplan-Meier survival, they published their outcomes at 2 years and 5 years. We'll concentrate on the 5 years after randomization. The primary endpoint, which is all-cause mortality, non-fatal MI, and a stroke, was significant in all of them. If you look at the all-cause mortality, it was 16% in PCI versus 10% in CABG, significant. If you would look into the MI, it was 13 versus 6, which is like double, right? In PCI, those who underwent PCI had double perioperative MI compared those to have CABG, very significant. Stroke, it was significantly higher in CABG, and it is very logic because it is a more invasive procedure compared to PCI. So in all the study that compare PCI versus CABG, stroke was always higher in a CABG, and we know why, because it's more invasive and it's not surprising us. Okay. Cardiac death was not significant. Okay, in terms of secondary outcomes, which is the major adverse cardiovascular event at 30 days and 12 months, again, it was significantly less in CABG, 11 versus 16. The death was not that significant. The MI, again, 5 versus 3, so almost like, 6 versus 3. Again, double in PCI compared to CABG. And look here, repeat revascularization was also almost like more than the double in PCI versus CABG. And that's what will confirm our hypothesis that when you do a PCI, you only treat a focal disease. But the diabetes patient usually have a multi-segment diffuse disease. So you only address one part of the coronary, which is the segment with the highest stenosis. So that's why the repeat revascularization is expected to be double in PCI versus CABG. Okay. This is just a graph which show you the primary endpoint, which is all-cause, the primary endpoint of death, MI, and stroke, significantly higher in CABG versus, significantly higher in PCI as compared to CABG. If you would come to death alone, again, significantly higher in PCI compared to CABG, that's at 5 years. And when you come to the discussion, again, we would say patient undergo CABG had significantly lower rate of a primary endpoint, including death from any cause. So yes, survival will be better in patient underwent CABG if they have diabetes. Okay, result consists with the report from a smaller retrospective study that was unpowered, like the Barry trial. Previous study has shown a major adverse event was driven by the repeat revascularization, but not survival, like the Barry study. It shows that the primary endpoint as a total is better in patients who underwent CABG, and mainly because of repeat revascularization. However, remember that study was unpowered. When we did the FREEDOM trial, it actually shows the survival benefit as a single component, like death was higher in a PCI group compared to CABG. So as we said, this study CABG benefit driven by decreased MI, death from any cause, both, okay, and repeat revascularization. Increased rate of stroke, as we said, is consistent with almost all previous study and meta-analysis, and it's expected. And you would say this is a more invasive procedure. We use a cross clamp, we manipulate the aorta, we cannulate. Of course, the stroke would be significantly higher compared to a less invasive PCI procedure. It's very important to mention that medical therapy was equal in both group. 90% use dual antiplatelet therapy for 1 year in PCI. However, in 3 months in CABG, despite this, it did not affect our results. Okay, and a limitation, this is low statistic power to detect interaction between the groups. It was unblinded. And for the major criticism about the study, the generalizability, only 10% of the patients who were screened, as you remember, there were 30,000 patients screened, only 1,900 were eligible or consented for the procedure. Okay, type 1 diabetes were only 4.5% of the patients, so it's really difficult to use this data to as an evidence for type 1 diabetes. In a conclusion, patient with diabetes and advanced coronary artery disease, CABG was superior to PCI with a drug-eluting stent. It significantly reduced death. It significantly reduced MI and decrease rate of repeat revascularization. However, it's in the cost of increased risk of stroke. Okay, how would this reinforce or change our clinical practice? As I told you, in reading any article, always look into what's the current guidelines. Until 2014, it was class 2A. Just a preferred CABG is probably recommended and a preference to PCI to improve survival in patients with coronary artery disease and diabetes. 2012, FREEDOM was published. 2014, and Focus update was released, and CABG was upgraded to class 1 indication for patients with diabetes to improve survival. Okay. Now we have the recent guideline, which is 2021, and alhamdulillah, it hasn't affected the guidelines. It's still class 1 CABG with specifically Lima 2-LAD is recommended for patients with multivessel coronary artery disease and diabetes. So we know that it affects the 3-vessel disease, but did not affect the left main, and it did not affect the diabetic patient. It's still class 1 indication. So do you guys have any question? I tried to summarize it as possible in order to have more discussion. What do you think about the trials? What do you guys have learned?
Well, Dr. Mariam, you made it very easy.
I tried, yeah. So that's why I want you guys to remember, when you remember FREEDOM, you remember what's the things like primary endpoint. Yes, it's survival. It adds survival benefits. MI, it decreased the MI compared to PCI, and decrease rate of repeat revascularization.
Yeah, this is very clear.
Any questions?
يعطيك العافية.
الله يعافيك. I know you guys will have a lot of trials. Like today, you guys discussed the STITCH trial, hypothesis 1 and 2, and we discuss the FREEDOM before we discuss the syntax and the coronary. So what will I advise you in order to not to forget this, because you need it in your general discussion with cardiologist or the patient, is just to summarize those trial in 2 sentences. Just say, for example, FREEDOM, studies coronary artery disease with or without coronary bypass. Without diabetes. Coronary artery disease with diabetes, PCI versus CABG. The primary endpoint was death, MI, and stroke. And then just say significant or not significant. Don't remember the numbers. Just say significant or not significant لصالح مين for the CABG. Okay, that's it. That's what you need to know from the freedom. Small arrows, you can put an arrows on the survival increase with the CABG, arrows with MI and repeat revascularization. So you know when you come to go and, for example, discuss a case with our colleagues or in a consenting patient, you would know which study and what did it show. Instead of like having, a presentation of 30 slides, you would have it in 2 slides. So I'll show you what I was doing for my exam. Second. So these are the study the randomized or study that was included for the exam. For example, if you come to the coronary, I just write coronary. I write what is it, what's the difference on pump versus off pump, right? And then the primary endpoint, composite outcome of death, MI, stroke, renal failure, dialysis. And then I will put the numbers and I will remember if it's significant or not significant. So I summarize the whole studies in this paragraph. This is at 30 days and this is at 5 years. So when I want to go, I scan around it, off versus on pump, not significant. Okay, 23 versus 23 at 5 years. The same things when you go for the 10 years. You go for, this is for example, the Ruby trial. And if you go down and you check the syntax again, 1,800 patient CABG versus PCI. What is the primary endpoint? Significant, not significant. Sometimes I don't put the B value. I just say S, significant, NS, not significant. Significant, not P value, significant, not significant. So you would know. Okay, so you need to have this summaries of the trials in 2 sentences, just 2 sentences. I'm not sure if I have it. 1 second. Yeah, so this is no, it's this one. Review, okay? So you have all the study, just the number, what is it about, all-cause death, 10 years, 20, 21, significant, not significant. Freedom, 1,900, the patient, it's CABG versus PCI in diabetes. All-cause death, MI, stroke, 1826, significant, okay? Coronary, only 2 sentences. Excel, only 2 sentences. Noble, 2 sentences. Ischemia, 2 sentences. Of course, you need to read it once, but then you have to have those summaries in order to remember them.
A very beneficial way of remembering things.
Yeah, because you will come across it. There are a lot of numbers, a lot of study, and you need to go through it. Sometimes I will forget the names of the study, so I'll open my note and go and see which article, which trials did compare. And with time, and if you do this small note, you will remember them.
Yeah, thank you, Sarah.
Guys, have any other questions?
Okay, thank you so much for the presenters, for you, especially Dr. Mariam, and we just conclude here, and I wish you all happy weekend with this cloudy weather.
Thank you very much. So guys, next week, in terms of the case study, Dr. Mohammed Tarabzoni will join you, and he will prepare case scenario discussion about aortic valve disease. Aortic valve replacement and TAVI, and it will be case discussion. So I hope you guys will have fun with him.
Thank you.
Inshallah, thank you.